Okay, we start our lecture about hematopoiesis from the general diagram describing us the hematopoiesis in general. What is hematopoiesis? This is the process of blood cell formation. So this is the way how erythrocytes, leukocytes, and platelets are formed in our red bone marrow. And as we can see, everything starts from the least differentiated cell, which is the hematopoietic stem cell. And next slide, we are going to discuss it in details. This is a very important cell because it gives rise to all our formed elements. And after division, it undergoes asymmetric division. Asymmetric means that one daughter cell remains as a stem cell in the red bone marrow, while another daughter cell differentiates, giving rise to either, there are two fates, either common myeloid progenitor arises or common lymphoid progenitor is formed. So hematopoietic stem cell, it has its potential to give rise to all cells of our blood, while common myeloid progenitor can give rise only to erythrocytes, platelets, and granulocytes with monocytes, while common lymphoid progenitor
Teacher,
gives rise to only lymphocytes. Yeah.
what does that mean by potential?
Bipotential, yeah, bipotential means that it can give rise to only two lineages, for example, erythrocytes and thrombocytes or platelets. So it can be means two. Bipotential means gives rise to only
Divide.
two lineages. Clear? So also we use the term unipotential. For example, unipotential means that it has a potential to give rise only to one lineage. For example, only erythrocytes could be formed, means that the cell is unipotential, and we'll discuss it a little bit later. So, hematopoietic cell, it is called multipotential. Sometimes you might see the term pluripotential, but we keep in mind that pluralis means that plural possibilities, and pluripotential are the cells of the inner cell mass or embryoblast in the blastocyst, as they can give rise to all cells of our body. Hematopoietic stem cell actually is not pluripotential because it gives rise to only blood, not to the skin, not to the neurons, and so on. So its potential is wide but restricted to the blood. That's why we don't call it pluripotential, despite, for example, in the Juncker textbook, you may find this term. Okay, so this cell is multipotential. Then it gives rise to two, common myeloid progenitor and common lymphoid progenitor. They are a little bit more restricted than the stem cell because common lymphoid progenitor gives rise to lymphocytes only, yeah, and myeloid progenitor to all the other cells except lymphocytes. So they have a more narrow potential comparing with the stem cell. After that, a common lymphoid progenitor and its fate we are going to consider next lecture, together with the thymus and together with the lymphopoiesis, because it is quite a distant process and it doesn't look like other branches of hematopoiesis. As for the common myeloid progenitor, today we are going to consider its derivatives in detail. So it is also split into two. It gives rise to granulocyte monocyte progenitor and megakaryocyte erythrocyte progenitor. And that's exactly what you're asking about, because these cells, they are bipotential. Bipotential megakaryocyte and erythrocyte progenitor gives rise to megakaryocytes and erythrocytes. And granulocyte and monocyte progenitor, it gives rise to many cells like neutrophils, eosinophils, basophils, monocytes, and dendritic cells. As for the dendritic cells, we are going to discuss them also in the immunity lecture about the immunity. Okay, this is in general the description of general branches of hematopoiesis, and it looks like a tree with a single stem at the center and two main branches, lymphopoiesis and myelopoiesis, and then myelopoiesis gives little branches, first splitting into two and then into small branches. At the end of those branches, there are formed blood elements like erythrocytes and megakaryocytes. Yeah, besides, I forgot to say that here I used abbreviation. It is widely used in the literature, so you have to know the full name. colony-forming units for megakaryocytes and colony-forming units for erythrocytes. This is another name for unipotential precursors because colony-forming units, they rapidly divide in cells and they form a colony in the red bone marrow or in a petri dish if we take them out of the red bone marrow. So that's why they are called colony-forming units. And they are unipotential cells because their fate is restricted to only one type of blood cells. And now let's look at this diagram, and you're going to draw this during practical lessons, and you're going to name every cell. And first of all, it looks like very difficult because lots of cells and they look like each other and it's very difficult to distinguish. But if you understand the logic of their division, how we subdivide them into classes, then everything will be quite clear for you. So let's look at this hematopoietic diagram, and at the beginning, how do you think what cell is at the beginning is here?
pluripotential hematopoietic cell
Stem cell, yes, I've just said that pluripotential is not an exact definition, but yeah, really this is the stem cell, and this is the single cell giving rise to all the others. Then this stem cell gives rise to two progenitor. What progenitor is here? How do you think?
multipotential, myeloid and lymphoid.
And lymphoid, exactly, thank you. So here is the myeloid progenitor, and another one is the lymphoid progenitor, so two daughter cells. Then, myeloid progenitor, it gives rise also for two cells. This is the precursor for granulocytes and monocytes, and this is the precursor for erythrocytes and megakaryocytes. And after that, you see that in the third class of hematopoietic cells, we can find cells, they look like each other and like previous classes, but they are destined to differentiate into only one cell of the peripheral blood. So how we call cells which differentiate into only one cell lineage? How we call it?
Forming unit.
Thank you. Exactly. Colony-forming units or unipotential precursors. Yeah, unipotential cells. Unipotential because this cell can give rise to only erythrocytes, so it is unipotential. While this cell is, how we call this cell? If this is unipotential, yeah,
colony-forming unit erythrocyte and
yeah, this
and thrombocyte platelets.
Yes, this is a common precursor, but if this cell is unipotential because it gives rise to only one cell, how we call this cell if it gives rise to two?
Multi, like so many.
Multi is here, for example, because many cells arise, but here only two types. So how we call this if two types arise?
Bipotential.
Bipotential, yeah, thank you. So here is the bipotential cell. Yeah.
Yes. Divide into blast cell or precursor cell.
Precursor. Yeah, we pronounce precursor. Yeah, exactly. Next class is blast of precursor cells, and that's what we are going to discuss. I just only wanted to fix that multipotential cells are here, and then bipotential and unipotential. And I want you to feel the difference that unipotential, they have a restricted fate, and bipotential a little bit wider, and so on. Okay, so the first class is stem cell, then the next class is myeloid and lymphoid progenitors, and in the third class we can see unipotential or colony-forming units. Notice that all those cells, they look like each other, they are indistinguishable because they look like small lymphocytes, because they are not differentiated. All changes occur only on the level of receptors and nucleus, but not in the cytoplasm. That's why under the light microscope, those cells are exactly the same. But starting from the next class, they start to grow, and as they have already chosen their fate, they start to differentiate. And the fourth class is called blast cells and precursor cells. And look that these cells, they look like each other. So they differ from previous classes, but they are similar one with another. And they are called blast cells, and this name helps us to distinguish the cells of this class. So proerythroblast, here we have what cell? How do you think? Do you recognize? This is
This is
Megakaryoblast.
megakaryoblast.
Exactly, yeah, megakaryoblast. And here for monocytes, what cell we have in the fourth class?
Promyeloblast.
Just here, monoblast. Yeah, here is the monoblast, and for granulocytes, how we call these cells? You've just said. These are, if here there's a monoblast, myeloblast. Yeah, thank you. Yeah, these are the myeloblast. Okay, so blast cells, proerythroblast, megakaryoblast, myeloblast, and monoblast, they look like each other. They do not differentiate. We can differentiate them one from another, but at the same time, they are much larger than previous one, and they divide, of course, because the name blast means that they undergo mitotic divisions. And after that, we can see a pool of differentiating cells. So starting from the fifth class, cells, they start to acquire specific features in their cytoplasm, and sometimes this class is divided into two, something like cells possible to divide and cells where division is blocked. But sometimes they are considered as the single class. So the next class is called differentiating cells, and that's what we are going to discuss in details. But before doing that, before considering every branch of hematopoiesis, I want to give the general information about the hematopoietic stem cells, because it is very important. Those cells, they have a special antigen characteristics, something like CD34 antigen and CD90. That's how we can identify them with the help of immunocytochemistry or in different other methods. And what is especially important, that they, of course, reproduce some self-renewing capacity they have, and also they maintain their percentage on the stable level. It means that, as I told you, every stem cell, it undergoes a symmetric division. Asymmetric means one daughter cell is left as a stem cell, another daughter cell differentiates into the blood cells. And it helps stem cells always to keep their number on a stable level. And what important property or characteristic of the stem cell helps us to use them in practical medicine? This is the recirculation. I want to highlight that hematopoietic stem cells are not retained for 100% in the red bone marrow. They might enter the bloodstream and circulating in the bloodstream to enter another site of the red bone marrow. You know that in our bones, hematopoiesis takes place, and every spongy bone, almost every, harbors its fragment of the red bone marrow. And to equalize the activity of hematopoiesis between different bones, sometimes bones, they exchange stem cells one with another. And to do that, the stem cells are transported through the circulation. And how we can use this, how we can harness this possibility, this potential of the stem cell. You know that some patients, they need the transplantation of the red bone marrow, and due to some reasons, they have their own red bone marrow destroyed due to irradiation, chemotherapy, or cancer, not cancer, tumors of the red bone marrow.
So we take bloodstream.
What?
We take bloodstream instead of put because it's painful.
Yes, yes, that's what I told you. Exactly. So formerly, red bone marrow was obtained through bones, and for this purpose, the bones were perforated, and the procedure was very painful. Nowadays, transplantation of red bone marrow is not necessary because we can stimulate stem cells to enter the bloodstream and to take them from the bloodstream instead of the red bone marrow. So we should not perforate bones of the donor, but instead we can obtain from the bloodstream. It's much less painful, and it is much more effectively. And to stimulate stem cells to enter the circulation, we use the colony stimulating factor for granulocytes. A special treatment is performed, so donor is injected this granulocyte colony stimulating factor. It stimulates stem cells to enter the bloodstream, and after several days, just peripheral blood is taken, and then stem cells are obtained from the peripheral blood. It is very interesting, and I think this is the real progress in terms of red bone marrow transplantation. because it is widely needed all over the planet. Okay, let's not stop at this moment. I just want to highlight that hematopoietic stem cells, this is the only one type of stem cells widely used in practice, and other stem cells like embryonic, like fetal, they are not so widely used, and they're still waiting for their, how to say, use in practice. And now let's talk about every branch of hematopoiesis, starting from the red blood cells. So erythropoiesis, and it starts as all branches from the hematopoietic stem cell. This is at the beginning of erythropoiesis. After that, common myeloid progenitor. After that, bipotential cell megakaryocyte erythrocyte progenitor, and then colony-forming unit for erythrocytes. So if you have already comprehended the general diagram, now it is 2 times more easy for you to understand every branch, because every branch starts from the general process. So colony-forming unit is a unipotential cell, and it gives rise to the proerythroblast. But what we have to say here, that erythrocytes are the most numerous cells in the peripheral blood. So they have not only colony-forming unit, but also so-called burst-forming unit, which divides much more rapidly, and it gives rise to many erythrocytes. And colony-forming unit is stimulated by erythropoietin, while burst-forming unit by interleukin-3. Why it is important? Because both erythropoietin and interleukin-3 are synthesized artificially.
Erythropoietin produced by cell kidney and stimulate for production of mRNA, a component of hemoglobin. So hemoglobin is a protein produced by a ribosome.
Exactly, yeah, that's very good, because I've just wanted to ask you where it is produced. Really, kidneys produce erythropoietin. That's why patients suffering from kidney diseases, they have anemia, they have their hemoglobin level lower, and that's what you have to pay attention for. And after that, yeah, colony-forming unit, it gives rise to the next cell, which is blastum and proerythroblastum. As we have said, this is a large cell with many nucleoli, and then it divides, giving rise to 3 next stages: basophilic, polychromatophilic, and oxyphilic erythroblasts. So, who knows why erythroblast first stage is basophilic? Why erythroblast is basophilic? What it contains for hemoglobin synthesis?
Basophilic because have 3 polysome synthesis hemoglobin.
Exactly, polysomes, these are ribosomes, yeah, and ribosomes, they contain ribosomal RNA, and this RNA is negatively charged, so it gives its basophilia, because negatively charged molecules, they like bases, so they're basophilic. Next stage is polychromatophilic. Poly means many, chromatos means
many
color.
colors.
Many
and
colors.
Philic low. And
Yeah.
Philic low.
Why they are polychromatophilic? Because what they contain except RNA, except ribosomes?
Basophilia and acidophilia, and contain filled with hemoglobin.
Exactly.
And contain some ribosome. And
Yeah.
contain also ribosome, produce hemoglobin.
Exactly. So together with ribosomes, they contain hemoglobin. They start to produce hemoglobin, and simultaneously, concomitantly, they have ribosomes and hemoglobin. That's why we call them polychromatophilic, because they are basophilic and oxyphilic at the same time. And after that, oxyphilic erythroblasts, they almost have lost their RNA, so they are oxyphilic because of what substance? What gives them this oxyphilic appearance? What protein? What protein is accumulated in oxyphilic erythroblast?
Globin.
Hemoglobin, yeah, of course, hemoglobin. So first they contain only ribosomes, then ribosomes and hemoglobin, and after that only hemoglobin. That's why they change their color. And it is easy to remember if you understand the processes in the cytoplasm. That's why we explain them. So here they are shown in the diagram. First, basophilic cytoplasm, you can see it is of purple color, many ribosomes. Then oxyphilic appearance also is characteristic because here hemoglobin appears in this cell. And after that, ribosomes disappear and only hemoglobin is left. So this cell is completely oxyphilic. Also, along with this process, we can see that the nucleus decreases in size, heterochromatin becomes more prominent, so the chromatin becomes more condensed, amount of nuclei, number of nucleoli also decreases, and as a result, the nucleus shrinks and eventually is expelled out of the cell. And now we have the next stage, which is called reticulocyte. So the transformation from one into another is accompanied by the expelling of nucleus. Why we call the cell reticulocyte?
Reticulum endoplasmic contain.
Because of what? Repeat, please.
Because contain reticulum endoplasmic.
Exactly, yes. Last lecture we have discussed because they contain endoplasmic reticulum left in the cytoplasm, and as a result we can see that the cell is still immature, and when it loses endoplasmic reticulum and contains only hemoglobin, it enters the bloodstream and eventually it is called red blood cell. What is important to say that oxyphilic erythroblast, the synonym is the normal blastum, and reticulocyte sometimes is called oxyphilic erythrocyte. So do not confuse, and everything's very confusing in this way. Okay, so in general, we've discussed erythropoiesis with its stages. I think if you understand the logic, then not very difficult to remember. So here we have real images of those stages, and as you can see, basophilic erythroblast is given here with an extremely basophilic cytoplasm. Then polychromatophilic cell is here, and you can compare them. This is really a transient stage between the basophilic and oxyphilic. You see here purple cytoplasm, here pink, and between them really the transient stages here. And these cells are reticulocytes. They are especially stained with a brilliant cretyl blue to find and to demonstrate those endoplasmic reticulum remnants, because with the common conventional staining procedures, they are not very well distinguishable. Okay, also we have to say that inside of a red bone marrow, erythropoiesis is organized in form of nests or islands, and in the center of this island, what cell is what cell is located in the center? Maybe
Stitches?
what cell is put at the no.
Macrophage.
Macrophages, yeah, macrophages. So the cell macrophage, it harbors in its peripheral cytoplasm different stages of erythropoiesis, and it helps to organize the process by producing different factors. For example, interleukin-3 is produced by them, stimulating burst-forming unit here. Also, what do they do with the nuclei of the orthochromatophilic erythroblasts? What do they do with the expelled nuclei? What?
Nucleus is ejected, it undergoes phagocytosis.
Yes, undergoes phagocytosis. So they eat those nuclei expelled by erythrocytes. They also accumulate iron. They might phagocyte those defective erythrocytes and so on. So macrophages are very important cells in maintaining the erythropoiesis. Okay, let's move on. And here are some USMLE examples. I thought it is important for you to understand how to solve and how to deal with different questions. Actually, in USMLE, this is the American test database, there are lots of questions about blood, and I don't know in what subject you have to consider them. I think pathological physiology. But also, I think it is better for you to talk here. So, like an example, here you are given a blood smear of a patient, and you're given different examples of his diagnosis. Yeah, and actually, even if you do not read the condition of this task, but if you look at the diagram, you may guess the answer just even without the condition. So, in this diagram,
spherical in shape.
It's spherical in shape, and what is absent in the center?
Nucleus.
Not nucleus is absent, it's a normal situation, but if erythrocyte is of biconcave shape, what about the intensity of the staining in the center? What should we see in the center?
Function-wise, but I don't remember the name.
I mean, the center should be more lightly stained or the same intensity of the staining. I think I just want to say that if erythrocyte is of biconcave shape, it means that the center is a little bit thinner than the margin. Yeah, and as a result, the center should be most lightly stained. But in this case, we can see the homogeneous intensity. So there is no light center. And if there is no light center, then we conclude that these are really the spherocytes. Spherocytes because they have spherical shape, and the thickness is equal in all the dimensions. So there is no light center. So if you look at the diagram, if you do not see light centers, so you suspect spherocytosis. And also there are some examples of another pathological conditions which could be distinguished only by the shape of erythrocyte. And it's very helpful for you. For example, if patient has the glucose 6-phosphate dehydrogenase deficiency, erythrocytes, they look like bite cells, really, something like somebody bite them. After that, spherocytosis is what we have just discussed. You can see there is no light center. Besides, notice that here is the light center in this case, and these are the normal erythrocytes. Under normal circumstances, they have the pale center. But here, pale centers are absent, means spherocytosis. And sickle cell anemia, very widespread, especially in Africa. And here, those sickle cell erythrocytes with the pathological hemoglobin. Okay, then another example also could be considered by the blood smear. So you are given different diagnosis, for example, glucose 6-phosphate dehydrogenase deficiency, spherocytosis, and sickle cell anemia. Those three could be excluded because we have just considered what erythrocytes they have, and we can see here neither spherocytes nor sickle cell erythrocytes. So we understand that here thalassemia should be, and you should distinguish between the alpha and beta. And as in the condition of the task, it is given that a 6-year-old boy and his sibling, he had a sibling who died of hydrophobos fetalis. And we suspect that alpha thalassemia might result in the preliminary death, and beta thalassemia is not so severe as alpha thalassemia. And because of this detail, you suspect alpha thalassemia, not beta. But I think that in pathological physiology, you're going to return to this topic, and we give now you this example only for you to understand that basic knowledge is very important to understand pathology in future. Okay, let's skip another tasks and complete erythropoiesis. Actually, we have already discussed that erythropoietin increases the production of red blood cells, and erythropoietin differs from other factors because it stimulates only red blood cell production. There are many regulatory factors are given in your textbook, and they usually stimulate several branches. But erythropoietin stimulates only erythrocytes, and it is very convenient when we use erythropoietin in practice. Okay, and we are going to consider the development of platelets or thrombopoiesis or thrombocytopoiesis. This process is not very complicated, but very difficult to pronounce different cells. So everything started from hematopoietic stem cell, common myeloid progenitor, megakaryocyte erythrocyte progenitor, and at last colony-forming unit for megakaryocytes. So this is the unipotential precursor. Then among the blast cells, we have megakaryoblast, and this is the last cell with mitotic activity. Notice that thrombopoietin stimulates it. It is also produced in the liver and kidneys, and this is a factor also artificially produced for practical treatment in clinical in practical medicine. Then next stage is pro-megakaryocyte, and it undergoes endomitosis. What does this mean, endomitosis?
Number of chromosomes increase, but still don't divide.
It doesn't divide, exactly. So unlike mitosis, when cell is divided after the chromosomal number increases here, there is no division, so nucleus enlarges, and at last it becomes the largest nucleus in our body, up to 64N. And this cell is called megakaryocyte, and tips of its processes are pinched off, giving rise to platelets. So platelets, these are the fragments. And here megakaryocyte is shown with the electron micrograph. We can see its processes based in the bloodstream. And here we can see the comparison of the size between the megakaryocyte and all the other normal cells. So megakaryocyte is polyploid giant cell of the red bone marrow. And it has its demarcation membrane system at the periphery, and it is represented by invaginated plasma membrane. It invaginates and coils inside the cell, and this coiling stimulates some formation of processes and their fragmentation, and it facilitates the formation of platelets in this way. And as you remember, that demarcation membrane system is left in platelets, and how we call remnants of this system in platelets. Do you remember in the platelets we have membrane zone, and it was represented by 2, and one part of this system was represented by the remnants of demarcation membrane system of the megakaryocyte. So in the platelet we also have its membrane invaginated inside, and how the system is called in the platelet? Open canalicular system. Yeah, so open canalicular system of platelets derives from the demarcation membrane system of the megakaryocyte. Okay, and granulocytopoiesis, I think one of the most complicated because many transient stages. But we start from the stages so we are already familiar with. So hematopoietic stem cell, then common myeloid progenitor, then granulocyte monocyte progenitor, and it is stimulated by the granulocyte monocyte colony stimulating factor. Then colony forming unit. And notice that we consider all granulocytes something like they are developing according to the same algorithm, but starting from the colony forming unit, we have its own colony forming unit for every granulocyte. So its own unit for granulocyte, for eosinophils, for basophils, and for monocytes. So, oh, I'm sorry, granulocyte, for neutrophils, eosinophils, and basophils. So they all derive from their own unipotential precursor. There is no common precursor for them all. After that, we have myeloblast. Its own myeloblast for neutrophils, for eosinophils, for basophils. I just want to highlight. Okay, so myeloblast, we have considered in the general diagram, like megakaryoblast, like proerythroblast, they look like each other. But then after division, after mitotic division, they start to differentiate into the promyelocyte. And as you can see in the promyelocyte, eosinophilic granules appear. What is the eosinophilic granules? What organelles are they? Do you remember last lecture we discussed that eosinophilic granules?
Golgi apparatus.
Golgi apparatus produces them, and what organelles is it? What organelles are produced by Golgi?
Lysosomes.
Exactly, lysosomes. Thank you. Yeah. So these are the lysosomes, and promyelocytes, they produce lots of lysosomes because next stage myelocyte, they do not produce lysosomes, but there are several divisions between this transformation. So the number of eosinophilic granules in myelocyte is decreased comparing with the promyelocyte because they do not produce their own, but they are formed as a result of division of the promyelocyte. Okay, myelocyte starts to produce specific granules, and they are the last cell with mitotic division. Besides the red line in my slides, means that cells above it can divide, cells under it can't divide. They lose the possibility to division. Okay, so myelocytes, they stop division, they continue to divide, and they contain specific granules. After that, we have 2 next stages, but they are characteristic only for neutrophils. For eosinophils and basophils, myelocyte directly transforms into the segmented stage. But for neutrophils, we have 2 more stages, like the metamyelocyte and the band neutrophil. Those cells could be found in the bloodstream. And what is the percentage, normal percentage of the cells in the peripheral blood? Do you know how many percents of the cells could be there? Up to 5%, actually. Yeah. So if we can find them less than 5%, then that's the normal.
If we find increase of metamyelocyte and non-segmented granulocyte, we suspect inflammation.
Exactly. This is the sign of inflammation.
And if we found the promyelocyte in bloodstream, is a tumor.
Exactly. Especially if we find myeloblast. So there is a tumor which is accompanied by myeloblast and promyelocyte appearance in the bloodstream, and it is very important, and that's why we investigate today hematopoiesis, because we have to know how to interpret the blood analysis, and increased amount of those two stages. Really, this is a sign of inflammatory diseases. But if we can find those cells, dividing cells, cells with their mitotic potential, this is the sign of tumor. So myeloblast should not appear, as well as promyelocyte, myelocyte in the bloodstream. Okay, and metamyelocyte and band, they undergo changes in their nucleus, and segmented granulocyte at last, it has its nucleus fully segmented. Okay, well, we have to say that also neutrophils, they are injected to the bloodstream, but some of them are left in the bone marrow. So bone marrow could be considered as a storage for neutrophils, and they could be injected into the bloodstream in case of inflammation. So we can frequently increase their number, not by stimulating their division, but just simply to inject into the bloodstream. Okay, and here we can see the diagram of the promyelocyte and myelocyte, and we can see the difference that xerophilic granules are produced in the promyelocyte and specific granules are added in myelocyte stage. Okay, and the last branch for today, this is the monocytopoiesis, or the formation of monocytes. And we start from the same hematopoietic stem cell, common myeloid progenitor, granulocyte monocyte progenitor, and after that monocyte progenitor, or the colony forming unit. This is the unipotential precursor. Then monoblast, like megakaryoblast, proerythroblast. This is the same stadium. It divides, giving rise to promonocyte. Then it just differentiates into the monocyte by changing the nucleus and acquiring some granules in the cytoplasm. And what is important to mention, that monocyte is not a terminally differentiated cell, yeah, but it is further transformed into macrophages. And macrophages, they are the cells of the connective tissue, and we are going to consider them next lecture. And at the end of this,
in this topic,
yeah.
what I don't understand is sinusoids or capillary type of capillary.
Yeah, exactly. Let's talk about. Let's talk about them. Actually, really, red bone marrow is given in your timetable before the topic blood vessels. So blood vessels will be considered at the end of the semester. So now we have to mention that our smallest blood vessels, our capillaries, could be of three types: sinusoids, then fenestrated, and somatic. And sinusoids, these are the most permeable capillaries. And just you have to simply remember that vessels and capillaries in our red bone marrow are very perforated. So they have gaps between endothelial cells. And it helps newly formed erythrocytes or leukocytes to pass through the wall of such capillaries. So sinusoids with very perforated vessels.
Teacher, please,
and it
can
helps.
you tell me about type of capillary?
Types of capillaries: sinusoids, somatic, and fenestrated.
Sinusoids, somatic, and
somatic and fenestrated. So somatic, they are the least permeable. For example, in our brain, we have somatic type, yeah, because our brain needs only oxygen and glucose, nothing more. So somatic capillaries are in the brain. Then fenestrated capillaries are in our intestine, for example, to absorb something, some nutrients. And the most perforated capillaries are in red bone marrow, because here not only oxygen is exchanged.
Thank you.
Okay, so we'll return to this question at the end of the semester. But in general, you just need to associate the word sinusoids with red bone marrow. Yeah.
Can you give me the name of this picture? Name of start
of this picture, a lower part of this. This one.
Yes, this one. Yes.
This one. This is the histological specimen of the red bone marrow. You know that there are two procedures. The red bone marrow could be aspirated, and then we can see only cells. And in this case, this is something like biopsy was obtained when we just take biopsy. Biopsy, you know, when we just take a part of the organ for diagnostic purposes, when we just take a piece, but several millimeters only. It is a
Teacher, can you
painful.
please give me the name of the book which I can found this name of the structure of red bone marrow?
I'll check. Maybe
Because
it
there
is
is
in
no
your
engine
textbook.
here. I think there is no
If there
engine
is no
here.
in Junqueira, 1 minute. I think in Junqueira in the 258 page, red bone marrow contains 3%. I don't know, maybe you see or not here in the page 258. You can see the specimen of the red bone marrow, low and high magnification. You can read in details about the structures we can distinguish there. This is the analogous image.
Thank you.
And what is important to mention that once again, red bone marrow for diagnostic purposes could be either aspirated or obtained through the biopsy, when we take a piece of bone tissue, several millimeters again. It is painful, and we have we need to have a strong, how to say, strong evidences that we really need to take a biopsy. So here biopsy is given, and we can see that large adipocytes are present there because with time, with aging, red bone marrow is replaced with the yellow bone marrow or with the fat tissue. And we can see fat is present everywhere in the red bone marrow. So red bone marrow itself is represented by different hematopoietic cells, and we have just discussed all of them could be found there. And they are organized in the three-dimensional space because of the reticular tissue stroma. So in the bone, in the spongy bone tissue, what we have is a reticular network, sponge-like tissue, again. And in this, if you imagine the sponge sodden with the hematopoietic cells, this is exactly the red bone marrow. So sponge itself is represented by reticular tissue, and it is needed to organize all the hematopoietic cells in the three-dimensional space, because hematopoietic cells, they do not contact with each other. And if we remove stroma, then they are going to mix and to be organized in the chaos. But instead, to put them properly and to organize them in a proper way, we need to have reticular tissue stroma. So next lecture, we are going to consider reticular tissue, and you'll get more information about it. Then the cells of one branch of hematopoiesis, they form nests. Here they are grouped as erythropoietic islands are formed around macrophages we have already considered. And with aging, red bone marrow is replaced with the yellow. For example, you can see that just after the birth, we have hematopoiesis in all our bones, but in adult organism, in our extremities, fat replaces the red bone marrow, and red bone marrow is concentrated around here. So with what we have to say, also we have to discuss the last slide today, the prenatal hematopoiesis. In the prenatal hematopoiesis, we have 3 periods. So only before the birth, our bones and red bone marrow becomes the primary hematopoietic organ. But before the birth, first we have our yolk sac and then liver as the general hematopoietic organs. And it is important to take into account because sometimes in the liver or in the spleen, in adults, we can find hematopoiesis, and this is the sign of abnormality. So let's look at those 3 stages, and that's all you have to know. So during the first stage, before the 9th week, yolk sac produce blood cells. Blood cells are produced inside the vessels, and we call this intravascular hematopoiesis because inside vessels, and megaloblastic because large cells are formed. Then, in the second stage of hematopoiesis, liver performs the primary role, and it lasts from the 5th week almost up to the birth. And in the liver, all blood cells are formed. But notice that hematopoietic cells arriving here from the mesoderm of the aorta, gonad, mesonephros region. So hematopoietic cells of liver, they have quite another region comparing with the yolk sac. So these are the two distant hematopoietic populations. So liver, it receives hematopoietic cells from this region. After that, liver gives rise to cells populating the red bone marrow. Okay,
Teacher.
yeah, and yeah.
How can formation of erythropoiesis?
Yeah, the formation of erythrocytes differs in the liver from the bone marrow.
Erythrocytes, teacher.
Yeah, erythrocytes as mature cells are not formed because cells, they enter the circulation with their nuclei inside. That's why in the prenatal period we can find nucleated red blood cells. And it is very important to mention because erythropoiesis is not so well developed. And like in the phylogenesis, you know that primitive animals like frogs, they have their red blood cells with nuclei. These are the least differentiated cells. And before the birth, we also have nuclei in our erythrocytes. So after that, in the red bone marrow, enucleated erythrocytes are formed. That's the difference. And starting from the 10th week, red bone marrow starts to function, and at the moment of birth, this is the primary hematopoietic organ. So this is in general the process. Do not forget that before the birth, what type of hemoglobin we use? Let's remember previous lecture.
Teacher, again?
What type of hemoglobin is used before the birth? You know, we have adult hemoglobin of adults.
We have a fetal hemoglobin.
Fetal hemoglobin, exactly. So what is the difference between the fetal and adult form?
They have a greater affinity of oxygen.
Exactly, thank you. Yeah, very pleasant for me to hear that you remember. Yeah, fetal, it has higher affinity because it takes oxygen from maternal hemoglobin, and just after the birth, it is massively degrading, and that's what causes the jaundice of the newborn child. After that, it is replaced with the adult. So in the fetal period, we have another hemoglobin, we have nucleated erythrocytes, and we have quite another sites of hematopoiesis like liver and the spleen. Okay, thank you for the attention. Today we just complete our lecture, and next time we are going to consider connective tissue. If you have any questions, then feel free, let's talk.